So, good afternoon again from the podium this time. So, having this table specifically dedicated to the Society of Social Pediatrics and Health Promotion, I think it is important to also give you an idea of things that are happening in the field, as is one of the projects that I'm going to discuss with you. And the reason I'm presenting this is because this is a project showing significant synergy between the academia and the community. Usually, we tend to isolate ourselves in our ivory tower and be there and try to solve problems without identifying the needs that lie ahead. So this is a description of the healing roots. This is a picture taken by my colleague, Charlie Brannas, who is co-PIing this project from the University of Columbia, from the Department of Epidemiology there. This picture is taken from the refugee camp in Mytilene. So we have here three major partners, and of course we have the network. Anastasia is one of the people who is going to be also involved in the project, and we also have the government, the local government, the Epirus region engaged in our activities as well. As well, we have two NGOs running one of the camps of the unaccompanied minors in the area of Ioannina, and also to identify family facilities there. So I have to make a confession. I'm a data person. So I'm a pediatrician by training and a consultant in public health, but my career is as an epidemiologist. So somebody would say, why are you here with us today? So this is a typical situation where the problem comes knocking at your door, because Ioannina is a unique place in Greece, where within the urban shell, the urban area, we have 5 refugee facilities, large refugee facilities functioning as a second stage of reception for refugee population. So we are not an entry site, but we are the site that receives people who have been cleared from the entry sites, usually the ones that are close to or on the islands. So we have seen during the pandemic that these communities show a distinct impact, a distinct behavioral pattern that is related to chronic health problems, and this perception affects how they respond to an emergency. During the preparedness and response at that point of the pandemic, we saw that refugee communities share distinct patterns, which were also affected by their mental health status. So within the pandemic, the refugee communities realized that anxiety is a major functioning asset for their attribute for their everyday life. So, and how this comes to One Health, and I would go back to what Jeff said and stop there and second that to every letter. Because if we go back to the root causes of armed conflict, which is, as I'm going to show you, is the main obvious driver for forced migration, we can see that we have issues, attributes related to the three main One Health components, which is the human health, the animal health, and the environment. So we have climate change, disease vectors, we have security to food, access to safe water, as you've before, and specific dietary patterns. That can be the background and constant background of populations in that situation. So in that particular grant, which is a Columbia Award, we were one of the 6 teams proposals to be awarded with the Columbia World projects and named so, along also in concurrence with the Columbia Center in Athens. We focused on mental health. We know that there is an increased burden of mental health for all the obvious reasons that Anastasia pointed out, but we know that we have inadequate access to mental health services within the refugee community. The obvious thing that we all discuss is, of course, the post-traumatic stress disorder, but it is not just PTSD. Depression and anxiety are prevalent among refugees and migrants, and these disease entities, they cause suboptimal social integration, obviously, and long-standing unemployment, which, as we know, creates, again, health issues, not only within the mental health realm, but also they further stress the mental health services capacity of host countries. In Greece, we have already challenges there, and this becomes more difficult when we have members of the refugee communities addressing this or being referred to these services. So, moving to children, 1 in 10 children worldwide are impacted by armed conflict. And something that is weird, and Dimitris, in his next in his next talk, will also discuss, I believe, something like that, is that you would expect that in major crises, children might be more protected. So it is the other way around, actually. So children constitute 30% of the general population in the world. And yet we know that they are disproportionately affected by forced migration, because we know that among the forced migration populations, we have 41% belonging to that age category. These ages, they impact in different age frames. So 1/3, we have children aged from 0 to 4 years, 42% children aged from 5 to 11 years, and 30% children aged 12 to 17 years. So boys and girls, they are equally represented. Also, what we have seen is that and mainly Anastasia could confirm that in the unaccompanied minors population, we see more boys compared to girls. We have, I think, only one shelter in Greece for unaccompanied girls, where they live exclusively. Yeah, 91%. Yeah. So a large number of these children are obviously unaccompanied in all sorts of ways. It is not the physical absence of the parent or the guardian, but it is also the lack of parental guidance and support, and the family guidance and support, even when the parent is there, and the parent cannot fulfill his or her parental role. So can we identify the problem is prevalent. Can we quickly set up preventive services for these children and youth? So here, again, the challenges are multiple, because the level of interaction, the level of impact of these interventions expand across different attributes of the social structure. So we target the individual, we must target the cultural group, we must target the school or the educational environments where these children come in and come out. They usually go from one school into the other, from town to town, and stay up to 6 months in the schools that they attend, because also of legal matters. We target the family, and yet we have also to take into account all these parameters that we will not have the time to address, that are related to any functional asset of human life that can be taken into consideration. So I'm showing this to convey the complexity. Social determinants, of course, this is the reason why we're here. This is the main focus of the conference. This is a survey. This is the output of a qualitative study coming from refugees from Bhutan, related mental health during the pandemic. So here, if you would take out the title, this would be determinants that could affect any community. So we realize that preventive services are not necessarily refugee specific, forced migration specific. So we are at this point of social happening, of historical situation, where within the communities we have popular groups with the similar problems without the armed conflict and displacement background. Of course, Social is where we give the most focus because we work in the beginning theoretically. We have now research coming up where biological aspects are being addressed. For example, very few cohort studies on refugee populations are available. And this is something that needs to be taken into consideration. And of course, the psychological aspects that are dealt with at the local stage, but they are not dealt in detail as in terms of resilience building, etc. So, regarding the epidemiological characteristics of the diseases that are affecting mental health wise these people, these are also affected by gender, and of course by the refugee status. So in the graph here, you can see the prevalence of the three major mental health entities: PTSD, depression, and anxiety, based on different stages of the refugees: asylum seekers, refugees, irregular immigrants, labor migrants, and Swiss residents. This is a study done in Switzerland. And again, here we can see a gender aspect of these again three disease entities: PTSD, high anxiety, and high depression, with the limitations of the tools that are usually used to deal these. And we can see that also women can be affected disproportionately in these populations. So how can we address this? As I mentioned, I am a data person. Evidence is my main area of interest in terms of my quantitative part of my work, evidence synthesis. So we should, when we started dealing with this project, the question is, where is the evidence? Okay, let's do a preventive intervention in the refugee communities in Ioannina, but which one? Based on what criteria? So we said that we would base these criteria on evidence that it seems relevant, consistent, and robust. Yet, when we looked at scoping reviews and gave a first look at the evidence that was available, we understood that there is substantial heterogeneity in prevalence rates, study designs, diagnostic criteria, cultural adaptation efforts, refugee population, and host countries. And that there is a major problem in data comparability. So data are there. Usually they are in the hands of the NGOs, which do the work, they do their duty, and yet they don't have the incentive to publish. They are not connected with the academia. So we have problems in aligning and harmonizing and standardizing the data, not only across countries or regions, but also over time. So we have an international initiative that is strong, it is loud, and yet we need the tools to be able to address that. And evidence maps are a first important step towards that direction. So we targeted an evidence map as our first goal in this project, because we envisage that an evidence map will elucidate the variation in the efficacy of interventions tailored for refugee populations. So we are now beyond the time of do something. We are now at this point when we need to do something that works. So, and we have to be able to understand that refugee communities are pivotal in attaining the developmental goals set by the UN, and that without appropriate data and implementation on evidence-based policies, this can never happen. So we will organize the evidence map, not only addressing clinical entities after the incidence of them and their clinical presentations, but also we will try to address prevention and related attributes that can serve as catalysts for mental health preventive services. So the sense of the individual well-being, the rights and values, the perception of knowing your rights and values, and the socioeconomic and connection are three integral parts of the resilience. And we target also these resilience enhancing studies, although they are very, very few. So our goal was to treat this as a standard medical problem, not medicalize it, but treat it as we would go about with a new cancer drug to measure and significantly improve the choice and pilot, the implementation of population and person level interventions related to mental health disorders, so as to be able to reduce disparities and improve the quality of life of individuals. Three major objectives. The first is to use the quantitative and qualitative evidence synthesis methodology to create the evidence map. The second part will be to create a roadmap using a stakeholder co-creation approach where many people will be involved under a co-creation framework. There, we would like to provide the community, the global community, with a document that will be multifunctional, that will be useful and used, where local communities can identify interventions and customize them to their own needs. And of course, to assess the feasibility of the Healing Rook's mental health roadmap as a tool for community healthcare planning via piloting this in our communities there. So I'm reaching now the end of my part of the discussion today. So the evidence map is one thing. Within the evidence map, we want to know the general characteristics of this evidence base, of this research-driven endeavor. But we also want to know which interventions are actually doing the work, which are efficacious, and which interventions and why. So this is very easy to say, very difficult to do, because you have to define effectiveness first. And in order to define the effectiveness of mental health related interventions, addressing prevention and treatment, you need to be able to harmonize and standardize the tools. And not all tools are culturally adapted, and not all tools are used by the refugee communities. Then finally, we will be able to create the roadmap and validate the roadmap. So along the way, we realize that we should add the second component in there. This is how the evidence map is starting to look. This is one of the templates we are using. So we have the interventions and the outcomes. I may warn you that here we discuss about complex interventions, which is even more difficult to describe and standardize. And of course, we have to take inspiration from other major initiatives like that, where we will have a provenance and bucket map. This is very important for regulator and policy bodies. They want to know where the attributes, the data come from. And here, this is a cancer-related paradigm example where we can see the various domains, so to say, that are addressed in the evidence from one of our previous efforts. Again, an intervention-based evidence map. Here we go to the very core of the assessment, where we grade the evidence that we have in front of us and see the various categories where this intervention belong to based on their distinct characteristics. A population-based evidence map. This comes from a US project, again on cancer, where we have the software tools to have this information, taking into consideration the limitations of visual representation. A weight of evidence map. This is a work that we have done on air pollution a couple of years ago, where we discuss how different clinical entities, different associations. So all these bubbles that you see, the little, the small, and the larger bubbles that you see in these graphs, they are meta-analysis. So formal evidence synthesis efforts, associating any clinical entity component with air pollution attributes. So among all this universe of data, you can see that strong evidence is there for only a few of the bubbles, if I may. So this is also important to know when implementation is done. And again, the UNICEF evidence gap map. So this is also something that is it will be the final output. This is something that needs to be aligned to our needs so as to be able to have a final product. So the fun part, so to say, and to be sarcastic about it, is dealing with the community, working with the community. This is our first stakeholder group meeting that happened in Ioannina in August 2024, where we went to this refugee site where unaccompanied minors are there, looking, being in a city in Greece, in a multicultural city, multi-religion city, as you know, Ioannina is, and yet focusing only on their smartphone and being directly linked to Pakistan. So with that picture, I am leaving you, and I'm open to discussions and comments.